has been a medication that has come up in discussion in a number of different forums. It came up this morning during our mentor medication-assisted treatment echo as well. So there are two different sessions. The one for today is going to focus on dosing and indications. So generally, what does gabapentin do? Where could we use it, as well as some of the dosing considerations that are specific and unique to gabapentin. So just to clarify, we're not covering any of the misuse, abuse, diversion, stigma stuff this time. That'll be at a different echo a little bit later on. So I thought it was helpful in trying to frame how best to set this up to look at how gabapentin works. So gabapentin is actually a branched chain amino acid. So amino acids are part of our body that are made, that proteins are made up of. And it's an analog of GABA, so one of our main inhibitory neurotransmitters. What's unique about this is even though it's an analog of GABA, it doesn't work on the GABA receptors. It actually works on one of the subunits of our calcium channels. So it binds to the alpha-2 delta subunit. So why is this important? Well, when gabapentin or pregabalin binds to the alpha-2 delta subunit of the calcium channels, it doesn't allow as much calcium to get into the neurons. Why do we need calcium getting into the neurons? That's how they depolarize. That's how they send their message. So if they're not able to depolarize, then they're not as able to release neurotransmitters. So it can overall impact the amount of neurotransmitter that are released. And as you'll see, it also impacts a number of different conditions that that neuronal transmission, the number of depolarizations, the number of times those neurons fire, are intricately, easy for me to say, involved. So I split this. I am definitely talking off-label today, quite a bit. So we're starting with on-label, FDA approved. So there are 3 brand name preparations for gabapentin: Neurontin, Grellis, and the Horizont. So for all of them, for gabapentin as a whole, the indications that are FDA approved are epilepsy. It tends to be adjunctive treatment for partial seizures. This is generally the first indication we get for a number of epilepsy medications. So it's not ethical to take patients with seizure disorders off of their medication. So most new seizure medications are adjunctive. They're added on top of something else. And that's to assist with IRB considerations. It did tend to be refractory patients, and it's been approved in patients that are 3 years old and older. So it has some efficacy data in pediatric and adolescent patients. The other places it has official FDA approval is in post-herpetic neuralgia. We start to see some of the neuropathic pain, as well as moderate to severe restless leg syndrome. And that one is one of the newer indications for one of the newer preparations. So those all are involved with neuronal depolarization. So epilepsy, if you have neurons that are firing rapidly, neuralgias, so nerve pain if they're firing repeatedly, and restless leg syndrome as well. So all of those seem to make sense. We are about to take a total left turn as we start looking at some of the off-label indications. So I'm not really going to focus on these much. There is documented efficacy that it's more effective than placebo for each of these. We are going to spend a little bit of time here on the off-label indications. There are quite a few of them, and this is not a complete list, just for the record. The next 2 slides will go into detail for a handful of these. There are some that I, just for sake of time, didn't do additional slides on, so I just want to speak to those right now. The first 2, so for ALS, the amyotrophic lateral sclerosis, Lou Gehrig's disease, gabapentin has been used often in a, not for an orphan drug status, but more in a compassionate care type setting. So they've tried to use it for spasticity if there is any nerve pain or other pain associated with that. So it has a little bit of evidence. It tends to be more case reports. And actually, unfortunately, there are some reports of it not having any benefit whatsoever. So that tends to be a little bit more unique of a setting, a one-off type situation. For patients that have essential tremor, there are reports of gabapentin demonstrating efficacy for essential tremor. It has not been shown to be beneficial for other types of tremors. So nicotine-induced tremors, gabapentin hasn't been beneficial for, and actually there are case reports of gabapentin causing tremors. So it doesn't tend to be one of the first line options. It's one of the second line options for treatment of tremor. And I think it was, I don't know if I wrote that down. There was a 30% response rate, and response was defined as a 30 to 40% improvement in tremor. So less than half of the individuals were demonstrating improvement, but it was better than nothing, especially if those patients couldn't tolerate other treatments. So maybe some benefit for essential tremor. Other ones I'm just going to hit on here. Some case reports of treatment of nystagmus. So if a patient is looking at you and you have them move their eyes all the way over to the side, you actually can see their eyes, I don't want to say vibrate, but move back and forth. Sometimes that's an adverse effect that we see with medications, but can also be a neurologic condition. So there are case reports that gabapentin's been helpful with that. It's been investigated for treatment of Huntington's disease, although there are case reports of it exacerbating some of the movement disorders with Huntington's, but there's other evidence that shows that there are gabapentin-like peptides that might be helpful in improving some of the motor symptoms. So while gabapentin itself hasn't been effective, they are investigating that area. So that one I think is also a little bit out for to be determined. We need some additional information. The last one on here that I just wanted to draw your attention to is the vasomotor symptoms of menopause. So for patients who've been unable to tolerate some of the other treatments for menopause, they have used gabapentin in the past for some of the vasomotor symptoms, although it tends to be small populations that have used this, more open label type trials, and it's more beneficial than placebo, but not as effective as some of the other treatments that we have currently. So some of the estrogen treatments, some of the antidepressant medications. So as you can see from this list, it looks like a drug without a home. So it's been used for a number of different indications with varying degrees of success. And I picked a handful that have a little bit more data just to give you a little bit better of an idea of the evidence that exists, because you can see it. I remember vividly, I was in high school and my first job was at an independent pharmacy in my hometown. And I remember asking the pharmacist, and I don't remember what the drug was. And I was like, well, what are they using this for? And he listed off like 5 or 6 different things that were not related. And I remember looking at him, I'm like, so you don't know, like, isn't it your job to know? How do you not know what they're using this for? And it was a brand new prescription. He's like, well, that's what we're gonna ask when the patient comes in. He's like, but you could use it for all kinds of things. And that was my first experience with, hey, this may not have one home, it may be used for a whole bunch of different things. So some of the other off-label areas that gabapentin has been used in, alcohol use disorder. So this one actually has a growing body of evidence. Initially, gabapentin had been used in some of the patients that may had comorbid conditions, and they saw that it improved insomnia in these patients. it's been used directly for investigation for alcohol use disorder. And patients on gabapentin are more likely than placebo to decrease the amount of drinks that they have per day, as well as have a decrease in cravings. So this doesn't take either of these to zero, but it does show significant improvement compared to placebo. So gabapentin looks like it is developing a greater niche in the area of treatment of alcohol use disorder. It's been used to a lesser extent in patients that do have alcohol withdrawal, where they see a decrease in the symptoms that patients are experiencing with the use of gabapentin, although this is not being, I have a little asterisk here. So it was improved, but it may not be really clinically significant. And some of our other treatments do look to be much more efficacious for that withdrawal time frame. Because we have an integrated care population, I wanted to highlight some of the other little bit more medical indications. Patients with chronic cough, they've been given gabapentin. The outcome, I'm not an expert in chronic cough, but the efficacy endpoints that they had was improved quality of life, the severity, subjective severity of the cough, as well as the cough frequency. And in the small trials that were done, there was significant improvement in patients that were given gabapentin. So potentially as an option for patients who have chronic cough. And I believe that was done in a tuberculosis population. It's also a treatment for hiccups. It's one of my quiz questions for pharmacy students. Chlorpromazine tends to be one of the treatments for hiccups. Gabapentin also has some non-controlled trials that did report an improvement in the resolution of hiccups, complete resolution for those patients. A handful of them were hospitalized, some medically hospitalized, some psychiatrically hospitalized, but maybe an option for patients that have intractable hiccups. And then there have been some reports of improvement with itching, so pruritus, from a number of different indications. Case reports of improvement, so just saying, hey, we started this patient on gabapentin and they got better, or having the outcome be on the visual analog scale of how distressed they are from the itching and seeing improvement with the gabapentin. So we see improvement both on the substance use disorder side as well as with some medical conditions. But just because we use things off-label doesn't mean it always has a robust body of evidence. And that's why I wanted to pull up these last two. Gabapentin has been used quite a bit for anxiety disorders. There's I don't want to say a moderate amount of evidence that shows that gabapentin used adjunctively with antidepressants can improve anxiety symptoms. And it can also improve anxiety symptoms in conditions, not just generalized anxiety disorder, but also in more difficult to treat anxiety disorders like obsessive compulsive disorder. So when it's used in combination, it looks like it may have a good boost for some of those patients. If it's used alone, we don't have as much evidence as what we have with pregabalin. So for social anxiety disorder, there is one small 14-week trial that said there was improvement with gabapentin. And then with generalized anxiety disorder, there's a couple case reports of efficacy, but there also was a controlled trial that didn't see any improvement. So it's not as consistent as a monotherapy as being the only treatment for anxiety disorders that gabapentin can truly stand alone. It looks more like its role would be in combination with something else, especially the antidepressants. The off-label part that got gabapentin in trouble and probably started its bad name initially, or negative perspective, is its use for bipolar disorder. After it was approved for epilepsy, it was promoted for the off-label use as a mood stabilizer in patients with bipolar disorder. It could be titrated quickly. It tends to be sedating, so it was thought that it could be really beneficial for patients with mania. There was an open label trial that was done relatively early on, small group of patients that were intolerant to lithium and had partially remitted bipolar disorder. So their symptoms weren't bad. They were all outpatient. They didn't have to be hospitalized, and they were switched over to gabapentin monotherapy. They did see some patients had exacerbation. Some patients were unable to tolerate the gabapentin, but as they followed them, they didn't see a change in the rating scale scores. So they looked at both the Hamilton Depression Rating Scale and the Mania Rating Scale scores. So there was some suggestion that maybe it would help. But when they went after a specific indication, there was not enough evidence there to support its use as a standalone mood stabilizer. And in fact, there were quite a few patients that were switched to gabapentin that had bipolar disorder that were then left uncontrolled. So there was a massive lawsuit for Pfizer related to either decreased productivity, the fact that some patients had to be hospitalized, and there were some patients that unfortunately passed away either due to their actions when they were in a manic or depressed episode, or the result of a behavior they were taking because their bipolar disorder was uncontrolled. So there really is not good evidence to support the use of gabapentin in the treatment of bipolar disorder. So just because it has been used doesn't always mean that we should be using it there. So lots of different places that it could be used. And I think adding to the confusion, there are some issues related to its absorption that makes it a little bit trickier. So gabapentin itself, as I had mentioned, is an amino acid. So when we eat proteins, we have amino acid transporters in our small intestine that help us absorb those amino acids. That's how gabapentin gets absorbed. It's absorbed primarily in the small intestine, and it uses what's called the large neutral amino acid transporter. The problem with this transporter is that there aren't a lot of them, and they can be saturated. So as patients take gabapentin, there is a linear absorption. So the more drug you give, the more gabapentin you expect to see in the body. That happens until patients are taking 600 milligrams 3 times daily. It appears that after doses of 600 milligrams, there is too much gabapentin for those transporters to be able to actually absorb it. So patients may actually excrete more of the gabapentin than they, when you get above that 600 milligrams, than they actually absorb. So in cases like that, it is recommended that we split the dose, keep the highest dose at 600 milligrams, and perhaps give it 4 times a day if we need a higher dose. Because if they're saturated, they can't absorb more, even if there is more in the gut for them to absorb. So that's consistent for the immediate release medications. As I had mentioned, we have 2 other newer extended release preparations. Oh, I forgot I had this. Sorry. So bioavailability, the amount of medication that you take that actually makes it into the body. This is not a good curve. It means that the greater the dose that a patient is taking, the less of that dose actually gets absorbed. So patients that are on 100 milligrams 3 times a day, 80% of that dose gets absorbed. If patients are up to, I think this is 1800 milligrams 3 times a day, only just over a quarter of that dose actually gets absorbed. So if we split it to more than 3 times a day, we might be able to get that number to go up a little bit, but there aren't consistent pharmacokinetic models that have done that to be able to say how much that will actually go up. So you may have patients, if we're bumping the dose, who are saying, you know, we increased the dose. If you look at these bars between 2400 milligrams a day and 3600 milligrams a day, that's a big bump, but they're not absorbing. The bioavailability stays at just about 1/3, so they may not see as much of an increase as they would expect by having that increase. They'll get some, but not really as robust a response as they may have expected, and this may be why. So that was really the justification for the development of the 2 newer products. So the Horizont is actually a prodrug of gabapentin, so it has another chemical that's attached to it, and it can use a different transporter. So this transporter is actually in a different location in the small intestine, and there's a lot more of the transporters than there was with that large neutral amino acid transporter. So this one does not get saturated. So it is an extended release tablet, so kind of holds on to the gabapentin a little bit, and then is able to release to be absorbed a little bit later in the gut. And that way we don't have that same issue with the dose. So that was one way that they got around it. The other way was with Grellis. So this is, it has a cool visual on the website. I wasn't able to get that to pull over, but the tablet, once a patient takes it, it actually swells in the stomach and it will delay its release time. So it keeps it in the stomach a little bit longer before it moves into the small intestine, and it slowly releases drug over time. It still uses the same transporter, the large neutral amino acid transporter that can be saturated, but because it releases so slowly over time, it doesn't look that it saturates those transporters. So it takes a longer period of time to get to the maximum concentration. That's one of the reasons this should be given in the evening. But it can achieve higher concentrations than if they're taking the medication 3 times daily. So this came right from the package insert. So at an 1800 milligram once daily dose, we see higher concentrations than what we would see if it was 18 milligrams given 600 milligrams 3 times daily. So that was right at the end of where I said we would need to switch that. But even there, they do see a little bit of a difference. It doesn't kick in quite as quickly, so they may not see those immediate effects. If they had been on the immediate release preparation, that might be a difference for them, but that was one way that they were able to get around that. So because of that, the extended release preparations can be given once or twice a day because they do have those different absorption parameters, considerations, but the immediate release, the Neurontin in those immediate release gabapentin preparations do need to be given 3 times daily. If they try to split it to be a big dose only twice a day for ease, chances are they're not going to be absorbing most of that. And if we need to get above that 600 milligrams 3 times daily, it might be better to move to a 4 times daily dosing. So to wrap up, gabapentin works in the central nervous system on a number of neurotransmitters, and we see it used for all kinds of different conditions, although the level of evidence to support that really varies based on the condition. The total dose will also vary by condition, and we need to be really mindful of what preparation they're using and what dose is needed to make sure we can get the patients to optimal absorption.